Let's talk about passive or apneic oxygenation during intubation. Now, we know that there's a whole checklist of things that we do when we intubate a patient in the field. We know that these patients are particularly prone to hypoxia during intubation because this isn't like the OR where it's a mostly healthy person and we've had the opportunity to really set them up for success. So, of course, we're going to pre-oxygenate these patients. But one other thing we can do to help mitigate the chance of having hypoxia during intubation, right after we've given a sedative and then a paralytic, we take away the patient's ability to breathe for themselves. And then it might take us 15 to 30 or even sometimes longer seconds to pass that endotracheal tube, inflate the cuff, and then start providing ventilations through that endotracheal tube. So what can we do to help avoid that falling off that desaturation curve in that time we're trying to pass the ET tube? Because of course we can't BVM them during that time. We've got a blade in their mouth. Well, in comes passive oxygenation. Now, let me pause right here. This is an end-tidal CO2 nasal cannula. You should not be using this for your passive or apneic oxygenation because, look, most of our capnography nasal cannulas are either split, so one side takes in the CO2 and one side delivers the oxygen, or in some of the rest of these, both prongs are for capturing capnography, and the oxygen just comes out in little fenestrations or little tiny holes between the prongs. But this is the only cannula that I had at my house. I acquire things through expired supplies, and this is the only one that I have. So you should only be using a regular nasal cannula for your apneic oxygenation. And so what we do is we put this on the patient and we hook it up to full blast oxygen. That hood is driving me nuts. So we put this, remember in nursing school, they said, oh, the maximum you can give through a nasal cannula is 6 liters per minute. False. No, you can crank this bad boy up to all the way, like 25 liters a minute. So apneic oxygenation should be delivered at 15 to 25 liters per minute. And what that does is it just jet engines oxygen into the patient's nasopharynx while you're blasting it in at such a high flow rate that it hits the back of the nasopharynx and goes down into the lungs. This is not a replacement for high quality ventilations if, when we're not intubating the patient, but it helps us to buy some time and it greatly reduces the risk of peri-intubation hypoxia. And a cool little trick for you, when you're at the head of the patient preparing to intubate and you put these in, instead of looping it over the top of the patient's ears and going under their chin, loop it underneath their ears, and since it's tight on the top of their head, then once you intubate them, you secure it with your tube tamer, then this is out of the way and you just go yoink and it's out of the way.